Hello. So my name's Ashley Holt. I have recently been a simulation fellow at a place called SimWard in Wolverhampton, and I've recently gone back into training as a paediatric registrar. But I just wanted to talk a little bit about a simulation course that we've recently set up and piloted within the last 12 months. As we said, the point of this is a new simulation course to look at the management of acute behavioural crises, hence CAMS ABC, in paediatrics. So I want to talk a little bit about this thing called the PARITY of ESTEEM. This is something a lot of you may have heard lots about in the past. It's something that Royal College of Paediatrics are understandably very keen on. And what it is this concept that we should be valuing physical health and mental health equally, with the same access to services and the same training. And it's something that I think we've struggled with for a long time. We know that 1 in 10 children or young people do have a diagnosable mental health disorder. There's lots of evidence with slightly varying numbers, but still roughly 1 in 10. And it is this period of childhood and adolescence is a critical time. A lot of adult pathology in mental health and psychiatry presents in childhood and adolescence, and we're not always seeing it as early as perhaps we could. This has a huge impact upon later life, and we know that psychiatric illness can carry with it huge impacts on education, social impacts, social function, occupational things, quality of life, etc. We also have this term which I used to hear a lot when I was a new SHO about CAMS patients, and it's a term that I really hate. And very often it's more to do with the attitude of clinicians and what the attitude can sometimes be towards patients with psychiatric problems in a acute paediatric ward or general ward or A&E, because these wards are very busy. You're on call, you've got lots of patients, and people sometimes feel like there's not much they can do to help. And therefore, you kind of get, just going to see the CAMS patient in bed 5, and it's treated like a very quick clerking and review without perhaps as much focus into why they're here and what we could actually do to help. What we also have a lot of at the moment is increasing admissions to medical wards, and these are both paediatric wards and acute medical wards of young people and adolescents. So there's huge disparity in terms of where 16-year-olds, 17-year-olds go when they come to hospital, sometimes paediatric and sometimes acute medical wards, who also are very used to having to deal with adolescents, 16-year-olds, 17-year-olds in acute mental health crises. And there is little formal training in CAMS. So CAMS, for those of you who don't work in the UK, is Childhood and Adolescent Mental Health Services. And there's little formal training in this regard to a lot of general paediatricians. So, and these images were just me pointing out the focus, and a lot of our training being about this, which is more classical acute physical health, and a lot less impact and training so far in this. So we designed the following course, and I'll talk a little bit about how that runs. So it's a 1-day course using in-house medical faculty, 6 scenarios and 2 workshops, and at the moment we're running it about 3 times a year. So this faculty involves a lot of individuals, it involves a coordinator, it involves audio-visual support, it involves planted staff, nurses, security, etc. It involves a consultant from psychiatry, a consultant from paediatrics, a simulation fellow, and an actor who plays the role of an adolescent. We go through the scenarios, as you can see on the right. So we do a quick kind of communication icebreaker, and then we run through scenarios including acute psychosis, and then we have a tutorial where we discuss the legal frameworks involved. We have a scenario based around overdose. We have another one about a patient who's absconded from the unit and how we manage that. One about de-escalation of an aggressive or agitated patient, and also how we use rapid tranquilization and medications, which we have very little experience with as general paediatricians. We also have a scenario about self-harm and depression and history taking in that scenario, and we actually end the day with an acute case of a hanging. We then summarise and close the day and discuss feedback. So we use a combination of mixed modalities, so we use high-fidelity mannequins for overdose cases, we have a simulated ward environment, we have planted staff, as I've mentioned, and actors, and obviously we have a scenario with no patient at all who's run away from the ward. We make sure that we put a lot of lifesavers in case, so there's a telephone in that simulated environment, there's a consultant they could call for advice if they're struggling, so they're quite adaptable scenarios depending on the experience of our participants. So we've got mannequins, actors, and sometimes no actor, no mannequin at all. We debrief away from the simulation room in our different setting called the green room, and we use a diamond debrief model to do this. It's important this is a very safe space because understandably this is a massively emotive topic. We have a lot of candidates who may have all sorts of experiences of their own in their private or work or professional lives to consider. And we piloted this in 2019. As I said, we've now run 3 courses to date. We've advertised this locally initially to our paediatric trainees, sent out in our training newsletter, and then they get a pack when they arrive with a timetable and some tutorial slides, so they don't have to concentrate on taking notes, and they can take some of those learning points away with them. After the course, we send them out some relevant guidelines and further reading if they so wish. One of the other carrots, of course, of a course like this is we have a paediatric postgraduate curriculum called Progress, and this course quite nicely ticks a few of those domains for our postgraduate education, specifically around professional values and communication, as well as patient management, working in a team, and also safeguarding processes. So far across our 3 courses, we've had about 18 participants, as you can see here, and they range across a few experience. So again, for those not in the UK, SD2 is kind of our SHO level doctor, working up towards registrars, which are the vast majority of our participants. We've had a few senior registrars, a few staff nurses, and an advanced clinical practitioner as well. We collected some feedback from these people, both pre and post course, using a modified Oxford feedback form and some Likert scales. One of the things we wanted to know was how much teaching they've had in the past around childhood and adolescent mental health services. And actually, as perhaps expected, the answer is not a great deal. So a large number of the registrars had attended a regional teaching day on which there had been conversations about cancer. But 44% of our attendees had had no formal training on the management of acute mental health and paediatrics at all. In terms of general feedback, we'd asked them if they felt the course was appropriate, if it was relevant to them, well organised, if they thought their practice would change, and so far that feedback has been strongly positive. I also wanted to know how they felt about managing rapid tranquilisation, because I think of all the scenarios, this was a particular issue for a lot of people in terms of our experience. So 9 out of 10 of our attendees had no experience managing rapid tranquilisation in the past, but we do know it occasionally does happen. And we asked them before the course and after how they felt about managing this, and so we're pleased to see that their confidence had increased with that. Free text feedback also overwhelmingly positive. So they felt the simulations were realistic, it filled lots of their knowledge gaps, they felt the acting was fantastic, and lots of transferable management skills. And they're very keen that a lot of trainees should be offered to attend this. So the course, we feel, does fill this educational need. There is a lot of work in the past around our attitudes to mental health as paediatricians and generalists, about our experience, and also about young people's interactions with health services and things we can do to improve that. It's a nice mixed modality simulation. It does use quite an extensive faculty with small candidate groups. That runs the risk of making it potentially expensive, but I think we felt that it was important that all candidates got a chance to participate in one of the simulations, which does limit our group sizes to around 6 or 7. Feedback has been quite positive, and it is suitable to extend to a range of disciplines and specialities. We would be quite keen to get more nursing staff involvement, so one of our scenarios is specifically written for nursing staff to begin that scenario, and then for a doctor to join them later. So it's specifically written to try and get more specialties and disciplines involved. We're aiming to have more A&E staff attend and AMU also. So planning 3 times a year, we've got 3 dates in 2020 to come up. We've added, moving forward, I think it's always important to have continuing development in these things. So we've added a bit more disclaimers. We're very aware it's a very emotive topic, so we're trying to make ourselves a bit more aware of that in our immediate literature before we begin, and in our kind of pre-brief and stuff like that. We do discuss the fact it's an emotive day, and if people don't want to participate in a particular scenario, or even if they just want to observe, that's absolutely fine. So we're trying to make ourselves as safe as we can in that regard. And adding a few more post-course resources based around what the trainees told us they wanted. So we had people want to discuss more about eating disorders and more about the actual Mental Health Act paperwork and sectioning, so that's been included. As I've already discussed, with the potential to add other scenarios, we'd certainly like to include other specialties and add to our faculty. And in the long term, we can talk things like getting official CPD accreditation. And what it'd be nice to do in the future is to get some more long-term feedback from our trainees on how they feel it's helped them in their long-term practice. So thank you very much. Happy to take any questions.
Thank you, Ash.